You, everybody, and I want to thank especially the moderators as well as the organizers of the meeting today for this wonderful opportunity to give you this talk today on MR lymphangiography and beyond. So as you've undoubtedly heard so far, the lymphatic system is intimately related with the cardiovascular system. While the arteries and the veins deliver the oxygen and nutrients that we need to our tissues to survive, there's a small amount of fluid that actually gets deposited within the tissues because of these changes in the nutrients that are delivered. It's actually the lymphatic system's main job to take up that extra fluid and then bring it back into what ultimately is back into the circulation. It does this through a series of lymphatic vessels. Every organ in the body has lymphatic vessels, from the lower extremities that you can see here to the, as it courses up from there along the way into the abdomen, the liver lymphatics as well as the mesenteric lymphatics, the other largest contributors of lymphatic flow to the body, coalesce here in the central structure called the cisterna chyli. From here buds the thoracic duct, the main highway of the lymphatic fluid in the body, courses through the upper portion of the abdomen, through the chest, and ultimately connects back up here to the venous circulation, typically at the left venous angle. Along the way, it picks up the lymphatics from the heart and the mediastinum as well. Now, this system, when it functions properly, we don't notice that it's actually there. And so it's only when it's not fulfilling its main job that we start to see that it's actually dysfunctional. And as a result of this, what we typically see in a clinical standpoint is that it's all due to its inability to really remove this extra fluid from the tissues. And we see this as manifested by what's called lymphedema, ascites, pleural effusions, chylopericardium, plastic bronchitis, certain types of lung disease, and protein-losing enteropathy. All of these are causes of basically where fluid starts to accumulate. Where there's fluid that accumulates, we can see that's largely secondary due to malfunction of the lymphatic system itself. Now, the types of dysfunction that we see that can cause these can be simply classified into two sort of different categories. There are primary etiologies, such as the ones that we're talking about here today, such as KLA, GLA, Gorham-Stout, and these complex lymphatic anomalies. And there are secondary causes that we're not going to focus a lot on today, but they are intimately related, again, with the vascular system, and there are lots of secondary effects that we can see on the lymphatic system because of these other changes. Now, the reason why it's extremely important in these complex lymphatic anomalies is because there is data out there that suggests that if you have one of these complex lymphatic anomalies or diseases, and you have what are called signs of lymphatic dysfunction, such as pleural effusions, that this can significantly reduce the overall survival in these patient populations. So it's really important for us to understand, one, why these these patients develop different manifestations of the disease with lymphatic function, and two, is there any way that we can modify this to potentially change the trajectory of this unfortunate decrease in survival? However, in order to do that, we really need to be able to see what the lymphatic system looks like. How is it interplayed with these complex anomalies? Is there abnormalities also in the central lymphatic system as well as in the more other areas as well? And so in order to do that, we do what's called an MR lymphangiography-based technique. Here are some schematic representations of the three main areas that we access that are, again, the main contributors of lymphatic flow throughout the body. On the left is an inguinal lymph node, on the middle panel is the liver lymphatics, and on the right is the mesenteric lymphatics. Between these three different areas, we see approximately 95% of this flow that goes to the central lymphatic system. We access these different areas under ultrasound and place small 25 gauge needles in these areas that allow us to do our further imaging. To give you an idea of what this looks like, this is a typical normal intranodal injection where we can see the lower portion of the lymphatics from the legs as they start out in the inguinal region, go up the retroperitoneal lymphatics, and ultimately again opacify the central thoracic duct that courses up towards that left venous angle. The intrahepatic injections are very similar. As the liver lymphatics exit the hilum of the liver, they coalesce centrally around some para-aortic and parasplenic pancreatic lymph nodes, and ultimately connect again to the cisterna chyli and opacify the distal thoracic duct as well. And finally, the most recent imaging modality that we've developed is an intramesenteric modality. This injection here now opacifies and gives us our first look at what the mesenteric lymphatics do and how they're connected and supply lymphatic flow to the central lymphatic system in a very similar fashion, but there are different networks as the liver did. Now, what do we see as causes of some of the lymphatic dysfunction I've described before? Well, through a lot of other work that I'm not going to show you, we actually know that a lot of these disease states that we have are due to abnormal flow patterns within the central lymphatic system. You can either get flow that's going backwards towards the lungs, and this is a typical cause of chylothorax. The flow can then actually go into the airway itself and cause what we call plastic bronchitis. You can also see flow as it leaves the liver, instead of going into the central system, can go into the intestines, and this can cause protein-losing enteropathy. And finally, we can actually see that flow from the mesentery can also go backwards as well, and this can be a cause of ascites. So there are a lot of different manifestations, again, of lymphatic dysfunction. And what we've seen now in imaging several patients with these complex lymphatic anomalies is that there are clearly relationships between the central system and their overall disease presentation. And I'll go through a couple of examples of those for you now. So this is a patient with KLA who had significant mediastinal thickening. You can see here on the T2 imaging. And then with the dynamic contrast MR lymphangiography, we actually found that a lot of this thickening and edema that we see was actually perfused by the central lymphatic system. Now, because the disease states are heterogeneous, we do see different patterns. In this particular patient here, they actually had more multi-compartment issues, but they also had ascites, skin edema, as well as the mediastinal and pulmonary edema. And with the intranodal injections, we can actually see a different pattern than we saw before. There's no identifiable central thoracic duct, but there is copious amounts of pulmonary perfusion, as well as some suggestion of a leakage compared to as well, likely the cause of the ascites. And then even one step further, we can actually see there are some patients who have a normal appearing central lymphatic system. And this patient clearly still has the mediastinal thickening as well as a left-sided pleural effusion. But with injection into the intranodal pathways, we see that this is actually a normal appearing thoracic duct, indicating that, again, there's still a spectrum of this disease, and it may not always be communications with that central lymphatic system. But as we started to develop these multi-imaging techniques, we've actually identified certain types of diseases that are only seen with these additional multi-compartment image modalities. So this is an example of a 7-year-old with CCLA and a congenital protein-losing enteropathy as part of his manifestations. And here with the intranodal injection, you can see again, it looks relatively normal, maybe some dilated lymphatics here in the abdomen, but the thoracic duct is normal appearing and courses up to its typical location. With the intrahepatic injection, which normally shows us the etiology of PLE, we actually see here that the lymphatics that normally egress out the liver are significantly absent, and actually they reroute through what's called the capsular lymphatics in the liver that ultimately perfuses through a duct that goes through the mediastinum and actually goes to the right venous angle. And interestingly, when we did the intramesenteric injection, we found that this was actually the location as well as the source of the patient's protein-losing enteropathy, was that the mesentery itself was actually leaking back and spilling into the duodenum, giving us a new insight into these different disease modalities and the underlying etiologies for why they're developing this lymphatic dysfunction. And that was only seen by us being able to do this multi-compartment imaging. Now, once we have this imaging, what can we do about it? So there are a few different things that we can do, and I'll give you an example here of how we can use this to aid in treatment. So this particular patient had GLA, as you can see with typical findings here, and then very large bilateral chylothorax. Now, on our dynamic imaging component of things, we found that this patient had significant lymphatic perfusion of the intercostals on the left, as well as some branches going off towards the right lung, as the underlying problem with all these flow going backwards towards the lung and towards the ribs. So what we can do as interventionalists, we can actually target these areas that are causing these problems and these leaks and actually embolize these connections. And in this particular patient, we did it both percutaneously as well as via surgical approach, where we were able to access all the different areas that you saw in the MRI and actually place a embolization agent into all these different regions. And as you can see here, the chylothorax is essentially resolved, and even after the removal of the chest tubes, there was very minimal reoccurrence of effusions. But this is just one example of the many different techniques that we have to be able to treat some of these underlying diseases. Now, finally, the last example I want to give to you is another way that we can use this imaging modality. And this is a way for us to be able to help track and treat, not only diagnose, but also track treatment of disease. And this particular patient with KLA had a CBL mutation, and she was started on trametinib, a MEK inhibitor, in order to modify the downstream signaling pathways involved. And she actually had significant improvement. She had normalization of her pulmonary function tests, as well as her D-dimer levels and clotting parameters. And her lung parenchyma itself, based off a CT scan, actually significantly improved as well. But from an MR lymphangiography standpoint, from a T2 perspective, again, what she presented with a significant amount of mediastinal thickening, bilateral pleural effusions, And with the treatment of the disease, we actually saw a significant improvement in that with resolution of her effusions, as well as really decreased amount of mediastinal edema. It really translated again along with the dynamic component of the MR lymphangiography. This here shows a significant perfusion of the lungs on the left, but on the right, with treatment, we see a significant remodeling of this with much less and much decreased perfusion towards the lungs, which all correlates with her disease state. So this is definitely one way that we can actually, again, follow along with the different disease treatments that are available. So I hope from what you've heard so far is that as manifestations of some of the complex lymphatic anomalies, we see secondarily in a lot of cases, primarily a lot of flow disorders. And these disorders are very serious. They can be very life-threatening, and they have definitely been shown to decrease survival in the population. I hope that you've seen that imaging is really the first key step in diagnosis of these diseases, as you've heard previously, and then here with the adjunct of the MR lymphangiography, we're able to better understand what the complexities are of their underlying disease, as well as you've seen, one way that we can use this is to help guide therapies and to follow response to therapies. And then finally, with the advent of these new imaging techniques and treatments, we now have new treatments that are actually available to help treat some of these underlying lymphatic dysfunctions that we see. And with that, I want to thank all of you for your time and your patience.